So yeah, this is the romantic name of my thesis, heartbeat to heartbeat cardiac tissue characterization. It's based on the work that I mainly did at the Martinos Center, also at the University of Groningen, where I started my PhD. My official defense is, this is not my official defense. I just felt like it was good to give a short talk about what I actually did the last 4 years here. But my defense will be on the 6th of July, and I will share a link to that defense that you can virtually attend to, and I will actually virtually attend to due to all the travel restrictions currently. So you can, if you want, you can always share, attend that part of the PhD as well. But now I'll just go over a few things that I did over the last couple of years here. So yeah, my journey was actually, I started already at the University of Technology in Eindhoven, and during my master's, I already joined the Martinos Center for 7 months in the PETMR group with Ciprian Catana and David Izquierdo. And after that, I went to GE Healthcare. I know the enemy, but worked there for a little bit, had a lot of fun. But then Ronald Bora, who actually also joined the call, I saw, recruited me to do my PhD at the University of Groningen. And when I started there, actually a few months later, I moved to the Martinos Center, back to the Martinos Center for a few years. We were talking about 2 years at that time of research there, and we extended it eventually to 4 years, which is basically a whole PhD in the Netherlands. So that's a little bit of my journey, and that's why I've probably some people know me already longer than 4 years, but it started all in 2015 and I became like a full-time in 2017. Also, I'm not going to talk about anything in the brain, as most people actually do in the Martinos Center. I'll talk a little about the heart, so a little bit lower. Need a different coil for that too. But just to make sure that everyone is on the same line there, that you understand that that's what I'm talking about and not the brain. So this is actually an overview of all the papers I've published or are on their way of being published the last couple of years. And I'm going to be basically use these first 3 papers on native T1 mapping, T2 and T2 star mapping, and some other markers, MR-based markers. I'm going to use that as a motivation why I actually started working on cardiac BOLD imaging, blood oxygenation level dependent imaging, with simultaneous multi-slice, which was at Kavin, and eventually moved even further through vessel architectural imaging. So bear with me a little bit. I'll go through it step by step, and I kept in mind that not everyone is cardiac experienced here, so I have a few slides on cardiac MRI and cardiac diseases. So cardiomyopathies, that's actually what you focus on with cardiac imaging, cardiac MRI. So if you look at like normal heart, that all the way on the left, you can have different ways of having cardiac diseases. It can result into a dilated heart, hypertrophic heart, restrictive heart, and as you can see here, amyloidosis is also one of the things that can cause this restrictive heart. And I know that a lot of people do actually research to that, but it's also something that we see in the heart. And then you have ischemic cardiomyopathies. So those are more focused on the fact that there's a restriction or a limitation in the amount of oxygen that actually get to a certain area of the heart. And I'm not saying that all the others have nothing to do with oxygen or oxygenation or any of that equilibrium, but with ischemia, it's more focused on the fact that that is the main problem. I'll get back to that later in the slides, actually. So if you go in for a cardiac MRI, the main thing that you will do, or the first thing that they will do, is actually do a volumetric Cine MRI, which is basically a video of the heart in multiple directions. In this case, this is a 4-chamber and an axial slice. And they basically acquire this data so they can see how much volume, like how much the ejection fraction is, so how much volume of blood are pressed out of the heart every time it beats, and also how thick the muscle is. And that's had to do with the disease that I just showed with restrictive, hypertrophic, and dilated cardiomyopathies. You can actually see the changes there. So these videos are basically the first ones that you try to get. And then the main reason why people are referred to for an MRI and not just have an ultrasound or a CT to get this information, they have late gadolinium enhancement, which is used to identify ischemia or reduced cardiac function. So they inject a contrast, gadolinium, into the heart, and it washes out of normal tissue faster than infarcted tissue. So you can identify the area that the infarct, for myocardial infarction, where the infarct happened and is visible by hyper-enhancement, sorry. So it takes about 12 to 20 minutes to actually see this hyper-enhancement compared to the rest of the tissue. And actually, this is the main reason why people are referred for an MRI, so they know exactly which area is the infarcted area, and not only where the perfusion might be reduced. But then I got to the point, like, okay, these are like bigger changes. You can really visually see that there's something changed on the heart from just looking at the shape and the way it contracts. But there's smaller changes that might be appear in risk populations like hypertension, diabetes, or obesity that are not as clear as those bigger changes that I showed in the beginning, but those bigger changes might be the result of these smaller changes prior to it. So I wanted to focus on more like quantitative imaging techniques that might be able to identify changes in the hypertension, diabetes, and obese populations, and maybe other risk populations as well, but I focused on this in the beginning. So for this, I wanted to focus on quantitative cardiac MRI parameters. And with the first work that I did multiple analysis actually for T2 star and T1 mapping. And that's basically means that you go over a whole bunch of data that is published over the last 10, 20 years, depends on what kind of range you take, and see how much, how the T1, T2, or T2 star showed the difference between a disease and a healthy population. So it's a lot of data mining, basically. You just have to dig through all the data and order it. And resulting from that, I found that for fibrosis, inflammation, edema, fat infiltration, iron overload, and amyloidosis, you can actually see really well changes in T1, T2, or T2 star. Depends a little bit on what you'll see. But these are pretty big changes because with fibrosis, there is already scar tissue. And with edema, there is already inflammation, or there's already a problem present. And often that problem is already irreversible. So I started looking at like more newer techniques that are a little less applied in the clinic, because these T1, T2, and T2 star mapping techniques are actually used clinically sometimes, but not as much as they should actually. From this meta-analysis, you could actually see that they should be used a lot more when a patient comes in, just to get some extra information on either of these biological changes. For that, I focused on another technique, dynamic contrast enhanced imaging. And I know within the brain, we do that a lot, but you have to imagine that the heart doesn't have a blood-brain barrier because it's not the brain. So the contrast actually leaks out of the vessels a lot easier. So to overcome that, you often use a contrast agent that's a little bigger. And in this case, we use one with albumin binded. And then you can actually follow it over time and see the fractional blood volume and the permeability of the tissue. In this case, it was a mouse model. In infarcted tissue, we could follow it over time and see whether the infarct was healing better or worse. So it is sensitive enough to see those small changes over time, but we might not be able to detect something if there's this is an infarct that's healing, which is a major change in the tissue, but we probably will not be able to see anything in like an earlier stage. So we went also on to go to tagging MRI, which is pretty popular. I should click again here. Well, not too popular, but very old technique already. It's been around for, I think, more than 20 years actually already, but almost never used because you can slowly see that tagging grid that's over the heart, that's fading over the time of a cycle. It is really difficult to actually hit that in the right way. So a lot of clinical applications don't like to do it because it's a lot of redoing the same thing over and over again. And then with that data, also the analysis is not as straightforward to get those strains, that radial and circumferential strain graphs that you see on the left. But we did see that you could actually identify disease progression and therapy effects with this tagging MRI. So it is a very sensitive technique, but maybe not the easiest to translate to the clinic. And I actually do know that Manuel Morales is working on a deep learning-based approach to actually get the images that we saw all the way in the beginning, and I've added that here. So those CNEs that are just the regular ones that they acquire anyway, use those to get the strain data from that. And he worked on that, which makes it a lot easier to actually apply such strain analysis in the clinic instead of using another technique that's difficult to do the measurements. So, and there's other ways to do this too, but I think what Manuel is working on will be one of the most exciting things in the near future. So keep an eye on that. Then let me check here. Yeah. Then I mean, I did show now that those newer techniques might be interesting to do a follow-up after the disease and see disease progression or therapy effects. But it would be better if you can actually identify subtle changes before there's irreversible tissue remodeling in the heart. So to see before there's actually fibrosis or inflammation taking place, and then treatment might make it better or might make it worse, but you want to be way before that actually hits the heart, because then you actually already get damaged hearts, which can cause heart failure in the long run. So this prompted me to start looking at some earlier markers of this, and by reading through a lot of literature, it seemed like oxygenation might play a pretty big role in most of those cardiomyopathies that I showed all the way in the beginning as an early onset of the cardiomyopathy. So what I decided to do, since I was at the Martinos Center and a lot of people do blood oxygenation level dependent imaging, and I know for functional MRI, but you can also do this in the heart. So I used this technique to look at the oxygenation and see if there's any changes in those early stage or higher risk populations. So basically, blood oxygenation level dependent imaging, we use the paramagnetic properties of hemoglobin that's bounded to O2 or not bounded to O2. So they both have different paramagnetic properties, and which the hemoglobin on itself causes a susceptibility effect and changes the T2 star, while it also influences the tissue relaxation effects resulting in a T2 change. So we use those two actually as a measure for blood oxygen level dependent changes. So in the heart, there's multiple ways to do that. You can inject any pharmacological trigger that makes the heart working harder or makes the vessels vasodilate, but I chose to go for the most simple way, that's actually holding your breath. And I know that some BOLD techniques or fMRI techniques also have that as a pre-step or post-step, just to see that the whole brain lights up as a BOLD effect. So in this case, if you have normal breathing and you're holding your breath in the heart, you also see this vasodilation effect, because the CO2 increases in the bloodstream and the vessels are dilating like crazy because they want to have as much oxygen to the heart, like the heart and the brain as possible. So this vasodilating effect increases the overall oxyhemoglobin in the heart tissue, so in the voxels that you're imaging, and increases T2 and the T2 star, which also increases the MR signal. And there's been studies done with this breath holding technique to signal intensity, but they were not able to identify changes because signal intensity has a lot of other influencing factors. So I decided to actually focus on the T2 and the T2 star here, and not on the signal intensity, because that's a quantitative measure. And I was hoping I'm hoping, and I'm still convinced actually, that might be more sensitive to subtle changes than the signal intensity itself. So what I did, I teamed up here with Maaike Menhard, who worked already on the gradient echo spin echo EPI sequence when I got here, and trying to get this to work in the heart. So basically has multiple echo readouts per heartbeat, which is quick enough to do it within one heartbeat, and you have a T2 and a T2 star map each heartbeat, which is novel because normally you acquire those different echoes and different heartbeats, or even within different breath holds, and now you can actually do it within one heartbeat. So only that was already a lot faster and an advantage for that. But I wanted to use the fact that we could measure these T2 and T2 stars for every heartbeat to acquire the quantitative BOLD change. So I did that in 18 healthy volunteers and saw in all 18 healthy volunteers. Yeah, sorry, I already had a drink, of course, for the science on tap. All healthy volunteers showed an increase in T2 and T2 star over the time of a breath hold that was significant. So this we could identify as a BOLD response over the time of the breath hold. And also, if you acquire these over multiple slices, so we incorporated simultaneous multi-slice together with Cow and Setsampop, and you see that if we acquire 2 slices at the same time, the higher slice, or the more basal slice, actually had a stronger BOLD response, so a stronger change in T2 and T2 star than in the mid-ventricular slice. And this was actually significant overall, and I am looking at, I think there were 5 healthy volunteers that we tested, but it was significant for all of them that this response was stronger higher up in the heart, which is very interesting. And we think it has to do with how the vasculature, the major and the microvasculature is arranged here over the whole heart, and might be distributed differently in the top compared with the bottom, with more macro in the top and more micro in the bottom. So therefore also a different BOLD response can be seen there. But before I go into detail there, I wanted to show you that we actually also tested this in hypertension patients because that was the population that I was interested in to see if we could use this BOLD technique to identify their risk, their risk situation for cardiomyopathies. And we saw in hypertension that this, over the time of a breath hold, we even actually saw a decrease in T2 and T2 star instead of the increase that you saw in the healthy subjects. And this is actually significant over all subjects that we scanned. So we think that this actually might be a good marker for oxygenation differences between hypertension and healthy subjects. And I'll explain real quick what we think this means, because we think the hypertension population, instead of the healthy population with the breath hold, you have vasodilation. We think this vasodilation doesn't happen in hypertension patients, hypertensive patients, because they have way stiffer and less responsive vasculature. So in that case, if there's no vasodilation due to the CO2 increase, there's also no change in the blood volume and even a decrease in oxygenation for the tissue, which actually results in a decrease in oxyhemoglobin and a decrease in T2 and T2 star instead of the increase in T2 and T2 star that you saw before. So this is the theory behind this BOLD technique, and we should definitely apply it to way more risk population groups to see if we can identify also the severeness of certain diseases. So with that, I came to a new part in this research, because the oxygenation, yeah, it was different in different parts of the heart, and you can actually see it even throughout the whole slice that in some regions the BOLD response is stronger than in other regions, and therefore we thought, like, well, we can actually exploit this a little bit more, because if you inject a contrast agent, you can actually determine the vessel architecture in the heart. It's been done in the brain before, and we're like, well, we could at least try and see what happens if you inject gadolinium and look at the vascular structure, because if the arterioles and the venules and capillaries are distributed in a different way, you also probably have a different BOLD response. So to do that, we actually acquired every heartbeat. I don't show all of the images here, but every heartbeat we acquired the T2 and T2 star maps over the time of an injection of gadolinium, and we saw that this change in T2 and T2 star due to the gadolinium was not always the same in different regions of the heart, which brings me actually to the theory behind that. Is if instead of the hemoglobin here, the gadolinium passes through the vasculature, in fast-flowing arteries, the gadolinium has a susceptibility effect of the bolus to the T2 star earlier than it actually has an effect on the proton relaxation. So you see a R2 star and R2 here, plot here on the right in panel A. You see that the R2 star peaks before the R2 peaks. And if you plot that over time, you get a vessel vortex that's actually rotating clockwise. And I'll get to the importance of that later. But if the gadolinium passes in slow flowing venules, you can see that the bolus, the effect of the bolus on the T2 star, so on the susceptibility effect, is later than the effect on the tissue or surrounding tissue, so the tissue proton relaxation enhancement. So you see here that the peak in panel A, you see that the peak in R2 is earlier than the peak in R2 star over time. And if you plot those against each other, so every dot here is a time point representing the R2 and the R2 star in that time point, you actually get a counterclockwise turning vortex. And luckily, someone else already modeled that, that the different capillaries and arterioles and different sizes and oxygenations have different loopings. So different loopings clockwise or counterclockwise, whether you have arterioles or venules. So there was Kira Emblem that also worked with us on this project for the heart. So then the next step was to actually test this. And we saw if you have different regions of interest in the heart, whether it's more in an arterial dominant or more of a venule dominant area, you actually do see these different vortices rotating clockwise and counterclockwise, or being straight for mainly capillaries. And the difficulty here, if you're going to test this over multiple people, is that every vasculature is pretty unique. So it's not exactly the same where the major coronaries and major arterioles are compared with where the venules are. And of course, it's more or less. So we do know that, for example, in the septum, there's mainly capillaries, and there's no predominance of either of those two. So we decided to validate that area. And we saw that for 10 healthy volunteers in that septal region of interest, they all showed basically a straight line for representing a capillary or a mixture of arterial and venule vessels, and not a predominance of either of the two, which is good news, because from that you can get a lot of other measures like vascular volume, density, and caliber, which are interesting, but mainly can be used to compare healthy with diseased tissue. And at this point, we only have healthy tissue, so there's not a lot to compare to because we don't see a worse and a better side of someone. But these values are useful and can be further explored. So in future studies, we want to do this actually in animal studies, in large animal studies. We can take the heart out and actually use histology with CD31 and alpha SMA staining. We can use histology to actually identify certain the arterioles and the vasculature density, and can validate the values that we got from the vessel architectural imaging with MR. So that would be more like a future study. I mean, I started a little bit, but I don't have the main results for that yet. But I will keep working on that the next few months, so you'll hear more about that. Then, short overview. We did explore the native T1 mapping and whether it would be useful for to identify disease and certain and can be used as a biomarker for fibrosis, for example. We did see that T2 and T2 star can also be used for this kind of these kind of biomarkers. We used permeability and fractional blood volume to from dynamic contrast enhancement. We could determine that, but we have a little bit of a problem with the contrast agent there. So maybe a shout out to Peter Caravan. Maybe hint to this in cardiac imaging with new tracers. Then we have the strain analysis from tagging, but might be more promising to do this with deep learning algorithms in the future. And then we export T2 and T2 star mapping per heartbeat to be used for BOLD imaging, and we could see that it actually increased over time, so we can use that as a marker. And we also are able to do this in multiple slices at the same time, so we don't lose any time or have to do multiple red holds for that. And then we also showed that vessel architectural imaging would be feasible also for cardiac imaging, but needs some further validation. And eventually, I hope that the smaller changes are actually easy to be determined with this vessel architecture and BOLD imaging, and we will not have anyone with hypertension or diabetes or obesity progressing in any of those cardiomyopathies at a later point. So with that, I want to thank you and thank all my supervisors on this side of the pond and the other side of the pond for helping me during this these 4 years of turbulence research for my PhD. And I also want to invite you for the defense, but I just heard this morning that part of it might be in Dutch. So I don't know how exciting it's going to be to attend, but I'll figure it out if it's all in English or can be parts of Dutch. So with that, I would say thank you.